Well, Jacqueline, thank you so much for the opportunity to connect with you and your community. I help oversee the community partnerships here at Affect Therapeutics. So what that means is finding those local partners on the ground in those states where we're serving our members, trying to build out those resources as we need them. And Let me see here. We are currently in a smattering of states. We are in 9 states currently. We're hoping to be in another 10 by the end of 2023, and hopefully we will be in Alaska in 2024. A little bit of background. I'll just give a quick background about Affect and a little bit of how the treatment works, and then I'll kick it to Will, and he can talk a little bit more about the payer relationships and just our plans going forward. So Affect Therapeutics is a 100% telehealth treatment program, SUD treatment program for stimulant use disorder is our bread and butter. That's where our treatment was designed for, I like to say. We also do treat alcohol use disorder as well. So Affect Therapeutics is a pandemic baby. It came out of the pandemic 2020 when all the telehealth regs were rolling back. And our co-founder, Dr. Jeff DeFlavio, who actually, I'm not too sure if anyone is familiar with their groups Recover Together. They're an opioid use disorder outpatient. There's about 20, 30 of them throughout the United States. So treating the opioid use disorder, and in that space, he saw a really big gap in stimulant use disorder and specific treatment for that. They tend to be in a traditional IOP setting. They tend to drop out a little bit more. They tend to relapse a little bit more as well compared to their peers in the traditional IOP. And so, and research has also suggested that contingency management as well as motivational interviewing are two of the recommended practices for sustained recovery from stimulant use. So stimulants cover meth, crack, cocaine, prescription stimulants, MDMA in some cases is considered a stimulant. So the telehealth treatment. Through the treatment, our members, once they find their way to us, they're wrapped around with services. We recommend the entire treatment to be anywhere from 3 to 6 months, depending on the severity of diagnosis. And in those 3 to 6 months, our members, all through the application, through secure Zoom, so this is HIPAA compliant, they'll be meeting with their counselor 1 time a week through the app, through Zoom. They will be meeting with their groups twice a week, also through app, through Zoom. And then they'll be meeting once a month with an APRN or equivalent for any co-occurring disorders, which is, really not uncommon these days. And the APRN does have the ability to prescribe non-controlled substances to help with things like anxiety or depression or cravings in cases where it's needed. So while they're working this program, which is all through the phone, there's also daily engagements that are happening nonstop. So I have the application on my phone and I wake up every morning and it's, hello, you've got 6 challenges to complete today. And so this gamification that occurs when you wake up or when you look at your phone, there are, what is it? I believe according to the curriculum, there are over 500 exercises that are based on cognitive behavioral therapy, as well as some, I'm going to butcher it, so I'm not even going to say it, some matrix model. But so, and these prompts and these challenges, they also tie into their homework that they're learning in group as well. And so these daily prompts can be something as like, journaling, meditation prompts, healthy eating, exercising. And so as they're engaging with their treatment, as they're positively engaging, we are positively rewarding them with financial incentives. So that's contingency management, which is rewarding just the behavior you're seeking, however you reward that behavior. And so through Affect Therapeutics, we do that with financial incentives, and within 6 months, members can earn up to $599. So says the IRS. So we are listening to them. And but it's going great. And those are paid out in a fashion, they're more designed to be front loaded, to really help hit those centers in an exciting dopamine filling way to help gamify and engage them in recovery before the benefits of recovery are really noticeable, right? Because, deciding to get into recovery is already difficult as it is, so having a treatment that is accessible, it is, extremely effective so far as to our outcomes of data. We began treating members in early 2021. We have completed treating our 1,000th member. Is that right, Will? Not too over. So now we're over that. So we're over 1,000 members, and we're really excited about the outcomes, compared to a traditional IOP, which is, recommended 9 hours a week for stimulant users, just, stimulant users specifically, compared to an affect therapeutics model. We're looking at about 60% retention with affect at 8 weeks compared to a little less than 25% for a traditional IOP. So, overwhelmingly positive. And just excited to see where it goes from there. And then before I forget, what really I like to say where the magic happens for us is our care advocates. So, while they have their counselors, they have their groups, they have their APRN, we have these care advocates, which are our case managers, and they're helping our members for all of those things that happen that need outside of recovery, which is, always happening. It's invariable. So, it's anything from housing to employment services to assistance with appropriate ROIs. If they're working with, Department of Family Services, appropriate documentation they may need to show they're in treatment. So, they are there, and they are, whenever you look at our net score, which is net promoter score, which is 72, almost all of them are, I'd say speak to our care advocates and just the overwhelmingly positive impact they've had on the recovery. And I think that's what, in addition to having this be telehealth, I think that's just the little bit of difference that it makes right there. Once someone decides to find their way through us, which is either through, most typically is the App Store, the App Store that lives in all the smartphone worlds, and there's also community partners like you guys. And so once a member finds their way to us, there is once they submit their insurance or information, they're called care coordinators. I'm going to butcher it, but they reach out and they're immediately wrapping their arms around them like, hey, thank you so much that we've got your information. We're going to verify it. We're going to let you know how this treatment works. Here's how the rundown's going to go. Here's how you can get familiar with the app. And we're going to verify your insurance, and we're going to help set up your intake appointment. And so folks, once they decide to proceed forward with treatment, will have a full biopsychosocial with us through the app, through Zoom, all secure, within 24 to 48 hours, at the latest 48 hours, which is, in these days and ages, is, I think, just a fantastic offering, for folks, because that window for, I've made the decision to pursue recovery, it can be very, very small. And so having that time is crucial. And so I think that's also probably lends to a little bit of our success is the accessibility, of it. Like, you don't have to find transportation to get across town at Alaska. You don't have to, like, I don't know, take a helicopter to your nearest, like to your nearest island. Like,
you're 100%, you're 100% correct. That's one of the biggest barriers. Jerry, I'm going to ask you to step in. You're the connector here. You understand this space so well. You connected Affect Therapeutics to us probably because on the ground level, you see how much need there is. Can you say for a minute how you think that this treatment will be a game changer for Alaskans?
Well, first would be making sure that we can find resources for people to access, whether it be Medicaid. I'm not sure if you're a Medicaid provider in other states. If not, we have folks here who can self-pay. So what's the cost of an episode of care? And then getting on the applicable insurance panels, which is primarily Aetna and the Blues, I think are the largest ones here. But I think the advantage is that it is internet-based, and not necessarily helicopters people would be taking, but it could be float planes or snow machines to access treatment, we know, in the remote areas. But that would be the major thing, making sure that people have the right resources that can align with the business model so that people can access services. But the flexibility of being able to do it 24/7 online is absolutely needed here.
Wonderful. So I know that you've probably worked in other, rural or remote places. Cecilia, can you tell us maybe how that's been operating in other places where people really do need access, but they might live in a place that's harder to get one-on-one care?
So I'll actually allow Will to answer this one, since he has better insight and he's involved in our overall payer healthcare strategy.
Yeah, sure. So, we are currently treating members both for the employer-sponsored insurance, individual marketplace insurance, as well as Medicaid across a large number of states, and many of which have really strong rural pockets of those states, including Idaho, Arizona, Nevada, in the western U.S. And the overwhelming feedback, both from our health plan partners on the Medicaid front, as well as our individual members, is that it's been a just tremendous support to be able to access this without the need to travel. There's counties in some of these states that I mentioned where it is a hours-long drive at best to be able to get to treatment. And even then, there might not be availability. Now, I know it could be much further and much more difficult travel in Alaska as well when you're talking about rural and in some of the counties that we talk to in Nevada refer themselves more as frontier. And so this is something that it's been welcomed with open arms, and we've had great success in engaging folks in those communities and getting them into treatment when otherwise they wouldn't be able to access it. And so when we look at Alaska, our plan is to be able to enter across both the employer, individual marketplace, and Medicaid insurance types. We do have a national contract with Aetna. We will be pursuing Medicaid in the state, and would be pursuing other commercial contracts with the Blues plans as well. And so that's something that we'll be actively pursuing when we do enter the state, so that we can be accessible not only from a telehealth standpoint, but from a cost standpoint and an insurance standpoint for members. We find that's really important.
That's wonderful. There's so many similarities between some of the Western states that you're in already in Alaska. Cecilia, do you want to carry on? I'm sorry to have interrupted you. Do you want to carry on and tell us more, or should we open it up for conversation?
Oh, no, go ahead and open up. It seems like Jerry's already got his hand up. He's got things to say.
Yeah, Jerry, please.
So one question and one nuance to Alaska is we have 228 tribes. So how are you in other states working with tribal entities for tribal healthcare providers?
That is I can let Will answer that, but that's a really great question, because that was one of my questions for you guys towards the end. So you helped. Go ahead.
Yeah, so in Arizona and then New Mexico, which is another state we're launching quite soon, there's a large number of tribal communities as well, and we've been leaning on the local health plans and state Medicaid offices and their liaisons on that front to help make sure that we're educated and staffing in a way that is culturally appropriate, aware, and creating good equity and connection into those communities. And so in the case of Arizona, we work through Access, which is the state Medicaid office, and their health plan specifically designed for the tribal communities to be able to create that access to care, but also those connection points into the community providers, the tribal treatment courts, which Cecilia has done a lot of work to build those connections and relationships, and really bridge those gaps. And so whether that's attending events, attending conferences specific to those communities, and as well as providing all the resources we can, and connecting to the existing resources, that's how we look to be able to support those individuals in need. So we have some experience with that, but we know that, again, no two states are the same, and so we will want to get really well educated on the Alaskan community and make sure that we are setting ourselves up for success and for the success of the members that we treat.
Wonderful. I wonder if Dr. Rosier, I don't know if you have anything to add to this conversation about, you're in a remote area and probably have some experience with trying to have treatment for your patients.
Hi, I'm Elisa Roger. I'm a pediatrician on Prince of Wales Island. I've been here 13 years. Well, I was in Ketchikan for 13 years, just moved over here the past year. I'm in recovery myself for food eating disorder. So since 2014, have been active in 12-step programs. Because of that action, I recently attended a peer support training in Ketchikan. It was hosted by Ketchikan Wellness Coalition and hosted by the fire department there. It was an in-person training, and there are 13 people trained to be peer support specialists. And through that, we formed this coalition to try to get Prince of Wales and Ketchikan up and running with peer support. It's prior to the training. I think combined, we had 0 peer support specialists. So we're having weekly meetings with the state lead in peer support, and then Search has been attending, Prince of Wales Health Network, Ketchikan Wellness, Power of Wellness. So a bunch of different people are attending those meetings, and we're making great progress towards getting peer support on the island. In terms of access to care, as an example, I'm the only pediatrician on the island that I know of. There are no counselors on the island. So for example, if I have a suicidal patient and I say you need to get into counseling, there are 0 people I can refer them to. And there is a person over in Ketchikan, but there's a 12 to 18 month wait list. I am a huge advocate for both mental and dental health access on a national level, because it is so unfair that we don't have access, and it's a money issue. It's not, there are services available, Medicaid's just not paying for them. So we need to speak up, and we need to get help for people, because people are suffering. And I don't think I've answered your question, but I was on my soapbox and I said what I wanted to say. But if you want to ask me more questions, you can.
Well, yes, I do, actually. So essentially from what I see, and we're a small group, so I'm kind of breaking out of our form typically, but from what I can see, from what you've just said, if I'm on Prince of Wales and I have a substance use disorder problem and I need help, there's very little access. Something like Effect Therapeutics would be open, since it's virtual. Suddenly yes. I go from having no access to having lots of access. So how do you see something like Effect Therapeutics working on Prince of Wales, and what do you think the reception would be?
I think it would be great. Throughout our process, we've kind of worked similar programs, and none of them have gotten access to Alaska Medicaid, and probably 98% of my patients are Alaska Medicaid. So that's a key component in having this work. But there are programs out there, they're just not hooked up with Alaska Medicaid yet. But yes, it would be huge. It's very needed. And the anonymity of a virtual program is especially nice for an island where everyone knows your business.
I was going to mention, that's funny. So there's a community in Nevada, they call themselves a frontier community. They're like maybe 2,000 people strong. And, that was one of their big concerns of, when people would enter court and compelling them to get into treatment is that everyone's going to know their business. And, that is a consideration and a barrier to treatment. And that's, something that this offers. No one knows if you're on the phone playing a game or if you're working on recovery. So it's pretty interesting. It's a great feature.
Frontier is a classification. It's less than 7 people per square mile geographically, and where we are, it's 1.5 people per square mile. So it definitely is frontier out here, and that is a whole separate classification for funding for resources.
Good to know. Wow.
Awesome. Well, we're a small but mighty group. I'm going to open this up. We've heard from a couple of people here. I'll start calling on people, by the way. But does anybody else want to step up and say why? Yes, please, Nancy.
Yeah, I was just curious. What states are you guys in? I was looking at your website. I did not see if there was a list there of where you guys are located yet.
Yeah, there's a list. I can send you the link specifically to that, but we are located in Arizona, Nevada, New Mexico, Idaho, and then soon we'll be launching in the state of Washington as well to add some presence in the Pacific Northwest besides Idaho. And then in the Midwest, Ohio Valley area, we're in Ohio, Indiana, Kentucky, Tennessee, and now Missouri. And soon to be Arkansas as well. And then Southeast, we're in Florida. And then, sorry, 2 more states, tough to forget these 2. We're recently licensed and about to launch in Texas and California. So growing presence, and in the majority of those states, we are already live with Medicaid. And if we're not, we're in the process to get Medicaid approval.
Do you all work with because I know you said substance abuse is also on your radar there. Do you work with hospitals that are treating people with like liver disease disorders and whatnot so that they have that option for them? That's fantastic.
Yeah, so we have one example of a partnership through one of our health plan partners in Nevada where they have case managers embedded in a facility specializing in transplant for liver transplant. And so we work with them on getting individuals into treatment and coordinate care as part of that ongoing process and program. So we've done that with with a lot of success, a number of members there. And we look at specialty programs like that as a really good opportunity for us to be able to help folks. Another one that we've been building out is high-risk OB programs. So pregnant postpartum moms with substance use disorders are ones that are, we talk about stigma in small communities. I mean, the stigma with moms with substance use disorders is incredibly high and a big barrier to treatment. And so we work hand in hand with OB clinics, hospitals, emergency departments, and health plans on how we can best serve those members and get them into treatment as soon as they present with that diagnosis.
That's fantastic.
But yeah, I'll get that link for you on where we are and share it in the chat.
I've heard with other programs who are taking care of women who are pregnant. One thing they do during the treatment is create like a scrapbook for the mom to bring to the delivery. Usually OCS gets involved, Child Protective Services gets involved because there's admission of drug use, but that scrapbook or that documentation of getting help during the pregnancy usually does a lot to mitigate any issues with OCS. So it can be a pro instead of a con in terms of getting help during pregnancy.
So valuable. Thank you so much for sharing that. So we're a small, mighty group. we do this for 30 minutes. We're very close to time. I'm willing to stay on. It's such an important subject. I just want to open this up. Is there anybody else that would like to share what they're doing or have a question?
How can we help you guys? I mean, is there what can we do to support you, and what kind of, I mean, my plan is I'm going to turn around and put you guys all over social and be like, these guys are awesome, but I mean, I'm just curious if there's other things that you guys are looking for.
Yeah, I mean, the first step for us is research into does a state allow a program like ours? And so there are states where we've run into where they refuse to license virtual only providers. I'm hoping that's not the case with Alaska. And to be candid, we haven't dug deep into what the state does from a licensure standpoint. For your reference, we do get licensed as a level 1 outpatient treatment program in each of the states that we go into, and then based on that, get Medicaid approval as a outpatient treatment program. And so that's one of the first things we're going to do, is want to be able to dig in and let the state know that we're coming and see what it is that we need to do to be able to get approved, so that we can start helping people as soon as we can. Often, and why we were saying 2024 is often that process takes 12 to 16, maybe even 2 years, 12 to 16 months or up to 2 years to actually go from researching to being live with Medicaid. It takes a while. And so local knowledge can help us avoid those pitfalls and barriers and roadblocks to getting up and running. So always would love to be able to have conversations with people who know the state well and know the way around to help us navigate that, first off. But second, in parallel, so that as we do work towards getting up and running, want to be connected into people in the communities so that we can build those collaborative partnerships for us to be able to refer people to for community-based organizations, for additional services that are needed, whether that's primary care, OB services, employment access, job training.
Always number one.
All of those things, but also for people to be able to be aware of us and be able to refer to us too. And so we're constantly trying to build that awareness internally as well as externally. So those are the two big areas that we're looking to accomplish now, is just get some conversations started so that when the time comes, we're actually able to hit the ground running.
Wonderful. Well, yeah, so what I was going to say is you've got a great advocate. Is the person who introduced you to us, Jerry Jenkins, would be a wonderful person who can help you with some of those contacts. So, and of course here we'll also be doing that. So it's now 1:30 here in Alaska. I want to thank you both, Cecilia and Will, for coming today. I'm very excited about you coming here. This is just the beginning of our conversation. Is there anybody else that would like to ask one last question before we close? No? Well, what I'd encourage all of you to do is to find Effect Therapeutics online. You can reach out to me and I can always connect you as well. Please help me advocate for them. I love their long-term plan. Yes, thank you, Ryan. Let's everyone, thank you, and let's give them a hand. That was an awesome presentation. I think what I love about your presentation is that it was a conversation, which is a little bit atypical for us, but I kind of love it. It allowed us to have some questions and to learn more about what's going on Prince of Wales and kind of the challenges of working in frontier areas. I do think that you are meeting one of the biggest barriers, and I'm sure that Jerry would be able to say, tell us more about this, but I think the fact that you can do this discreetly in your car and not necessarily have to walk in or whatever, I think it's a game changer. And I'm excited about working with you. You know, as I said, this is a partnership you're looking to launch here in about a year. We will continue to have our relationship with you, and I'll follow up with you, Cecilia, and see where we can move this idea forward. Thank you so much for presenting today. Thank you, Will, for coming, and thank you all for coming. I really appreciate it. We'll see you back here in 2 weeks, and thank you, Jerry, for the introduction.
Thank you all.
much.
Thank you for having us.